Why don't we get this show on the road? And by that, I'll introduce Dr. Moreau, who's graciously agreed to give you guys a little lecture on the emergency room. And it's very appropriate, as I was saying, in St. John here, the second years have just got awarded, or a bunch of them, their emergency shifts for the coming term. Dr. Moreau graduated from Laval University in 2015, did his family residency in Rimouski. Too bad you're a little bit late for Sidney Crosby when he was there.
Yeah, a little late. Yeah.
It would have been nice though.
Yeah.
So he's head of the emergency department in Edmundston. He works as a hospitalist as well, part-time. What I found interesting looking at his resume was the ultrasound expertise that you're good with. I think we're moving away from the stethoscope to the ultrasound as the primary tool. So maybe you want to touch on that a little bit if you have time.
Yep.
And like I say, I'll be on the line for a little while, but I do have another appointment too. So Alyssa, I'll pass the torch at the end for a little Q&A if you like. But thanks again,
Absolutely.
Dr. Moreau, for stepping in, and I'll pass the microphone to you.
Thank you very much, Dr. Simon. Hi, everyone. Very happy to be here. I'm grateful for the opportunity to talk to you tonight. So, as I said, Dr. Simon said, I'm going to be talking a little bit to you tonight about what it's like to practice in the emergency room. So you probably noticed that I have a slight accent. So English is not my first language. So you might see me every now and then making a pause to maybe think about how to structure a sentence. I'm not having a stroke live on Zoom, so don't worry if I do that. It might happen once or twice during the presentation, and I hope you're going to like it. So let's get started. So the plan for the presentation, just a quick, a little bit of information about myself, but Dr. Simon already covered that, so it's going to be very quick. We're going to talk a little bit about why emergency medicine is an attractive specialty. We're going to talk about training and work opportunities in 2025 for potential emergency doctors, work-life balance, differences between urban and rural practices, what are the required skills and qualities to be a good ER physician, some questions you must ask yourselves before choosing EM. We'll talk a little bit about what's going on in the EMs right now throughout the country, and with a few hopefully interesting cases. And then we'll conclude. The objectives for the presentation is to give you guys a better understanding of what working in the ED looks like, and discuss the training paths and their differences, as I said, and the challenges in EM in 2025, and help you to decide whether EM is a good fit for you or not. So that's my goal for tonight. I don't have any conflicts of interest. So I'm not going to talk too much about myself. Dr. Simon already covered that, but yes, I do have an interest in ultrasound. I started as an instructor with CanFocus St. John last year. We did our first course in French here in Edmundston. So it was a very interesting opportunity, but I do also like simulation, and I'm involved with NV Trauma for their mobile simulation program. And that's a picture of me coming back from a bike trip. So apparently every ER doctor likes the bike, at least according to Dr. Glockenflicken, who I'm sure you know from YouTube. And I'm making an effort to maintain the stereotype that we like biking, but it is indeed a popular sport among ER docs. So why emergency medicine? If you told someone you wanted to do emergency medicine, you might have had that kind of reaction. But there are a lot of perks to working in the ER. It's a very interesting practice. First one being variety. So you're going to see everything in the ER. You can't get bored. It's impossible. And you're going to see people from newborns to older people, and even some demented or crazy ones sometimes, but that's part of the job. So I assume you know what this sketch refers to. If you don't, maybe look at the news a little bit more. So another thing that might be considered interesting or not, depending on your personality type, is that there's no routine. So you don't know what you're going to have on every shifts, and that keeps things interesting, obviously. One of the big perks, in my opinion, is that as in other medical specialties, you're going to use your brain a lot, but also your hands with a lot of interesting techniques like sutures, intubations, chest tubes, central lines, you name it. So it's nice to have that technical aspect in the work that you don't have in every specialty. You're going to use a lot of different tools, which is very interesting too. So I think one of the things that ER docs have is that they're very versatile. Going to have to use EKGs, chest X-rays, some skills in the CT scan readings is not bad. The ultrasounds machines, obviously, we do love our ultrasounds machines. I think it's pretty it's a well-known fact in the medical community. I'm going to use some IO drills, the chest tubes, central lines, the spinal tap, intubation, sutures, you name it. So a lot of different tools in your toolbox that keeps everything interesting and makes emergency the doctors very versatile. Another thing, I think it's true for all, or at least most medical specialties, but it's very rewarding in the meaning that you can quickly help people and see concrete results with your actions. So that's nice. You have the potential to have a quite significant impact on the patient's evolution by making the right diagnosis very quickly. And people who come to the ER, not always, but most frequently are kind of pretty anxious or distressed and feel vulnerable. So it's nice to have that potential to make a difference by relieving their anxiety or their pain. So very rewarding job. So let's talk a little bit about training now. I'm assuming medical students probably have a lot of questions about that. I was trained, as Dr. Simon said, I did the family medicine plus and the +1 EM year. So I might not be the best person to answer all the questions about the specialty program, but I do have a little bit of knowledge about that. So I'll do my best to give you a few infos about that. So the first path would be going through family medicine and stopping there. It's a 2-year program for now. I know they're talking about increasing it to 3 years, but we'll see about that. You could either work as a full-time emergency physician. I have some colleagues that didn't do a +1 and they're working full-time, at least here in Edmundston, and I know that it is true for many ER physicians. Your workload might depend on what other activities you have. For example, longitudinal care or hospitalization, obstetrics, for example, and different local departmental policies or regulations. The main downside, I would say, is that it may be harder to get a position in some academic or bigger urban centers that might require an EM training, either with a +1 or the FRCPC program. So about the +1, so you have to do 3 years of residency instead of 2, so 1 year of emergency medicine after the family medicine residency, or you could do a 3-year program that is an integrated program that exists with Dalhousie University, and I found out that there's a Northern Ontario School of Medicine that does that too. I think they're the only two faculties that do that in the country. So from what I understand, you basically do a 3-year residency, but with some of the EM training is kind of scattered around in the 3-year. Your rotations are going to be targeted towards acute care, so obviously ER, adult, but also peds, ICU, anesthesia, trauma, etc. So it's very interesting to have the opportunity to get a whole year training in those specialties and get some more skills and knowledge. You do have access to some fellowships like simulation and ultrasound, but those might not be considered as formal fellowships, like they're not Royal College approved as opposed to the FRCPC fellowships. There's a possibility to apply in most academic centers when you have that certification. And you could also challenge the exam if you want to do your 2 years of family medicine and then work a little bit. You could work for 4 years and then apply to do the exam and get the certification without doing the third year. One of the main advantages, I think, of that program is that it's a little more versatile than the FRCPC program, which means that you can do something else if you want. So as a family doctor slash EM doctor, I can do hospitalization. I could decide to open an office sometime. I could do obstetrics, you name it. So you're not stuck in that specific specialty. Although specialists also do have some freedom to change their practice. So we'll discuss that during the next slide. So the FRCPC program is a 5-year specialty program. So you become a specialist in emergency medicine. You do have access to some formal fellowships that are recognized by actually there are some Royal College subspecialty programs that could be ICU, pediatric EM, toxicology, for example. So this is nice. They're generally recognized internationally. And as in with the FCC Family Medicine +1, you might be required to do that to work in some academic or large urban centers. People who choose that route tend to have more training in research and also teaching and admin. So if you're very interested in those things, the 5-year specialty program might be a good choice for you. And as I said, you do have some opportunities to work outside of the clinical EM work, but it's probably less varied than with the CCFP EM route. But I do know some specialists that change their practice over time to do something else than the EM clinical work. I'm going to get a sip, I'm sorry. Sorry about that. So might be interesting to know the CCFP EM positions by university in 2025. There are 128 spots throughout the country. I think those have been increasing a little bit over the past years because there is a high demand for ER docs nowadays. And this has been the same for the specialty program. This year, there are going to be 82 spots. And those numbers have gotten higher and higher over the years. So there's a graph here that shows that in 2014, there were 71 spots. 2 years ago, 77. And it's probably going to keep getting higher and higher because of the shortage of ER docs throughout the country. You might notice as well that there are usually over 200 applicants every year, and most of them list EM as their first choice. So it's quite competitive. So it's a good thing to maybe prepare yourself and make sure you have a good portfolio for your applications when you go through CARMS if you're interested in that program. About work opportunities, this graph is pretty old. It's from 2015 actually. So the 10-year column here reflects the situation that was predicted for today. I couldn't find some more recent stats, unfortunately, but I'm pretty sure that those numbers are probably accurate because we've been seeing it here in Edmundston, everywhere throughout the country. The shortage in emergency physicians is real, so there will be plenty of work opportunities for people who want to work in the ER. There's no doubt about that, and that's probably not going to change for the next 15 to 20 years. So now let's change gears and maybe talk a little bit about the work-life balance, which is always a popular topic and for good reasons. A full-time emergency physician usually works around 29 hours per week. At least that's the reality for ER doctors in Vitalité in New Brunswick. So that comes up to approximately 14 8-hour shifts per month. Add to that time for follow-ups, meetings, committees, teaching, admin, research, any other activities that you might be interested to. And you must plan some time to reset after a stretch of night shifts or evening shifts, for example, because it is shift work. So even though you have a day off, let's say on Thursday, if you worked overnight shifts Monday, Tuesday, and Wednesday, your day off on Thursday is going to spend towards sleeping and recovering from those shifts. So you got to take that into account. So the schedules are basically irregular but predictable, meaning that you have your schedule in advance and you know when your shift starts and pretty much when it ends, and you know that when you're going to get home, you're not going to have to take calls unless you're involved in some other activities. But if you work as a full-time ER doc, you won't have to take calls, which is nice. You can expect to work about 1 out of 2 to 3 weekends, depending on where you work and if you have enough docs in your team or not. So in summary, there's the potential for a reasonable amount of free time, but you will have to work some unfavorable hours, evenings, nights, weekends, and you have to be flexible to some extent to navigate through those kinds of schedules. So now let's talk a little bit about the differences between urban and rural practices. So the table I created, it's from my own personal opinion, but keep in mind that this is a spectrum. So there are very big academic urban centers in like Toronto, Vancouver, and Montreal, for example, but there are also some semi-urban centers, regional centers here in New Brunswick and Edmundston. I would consider a semi-urban, for example. And there are also some very remote centers where you have maybe basic labs and X-rays and nothing else. So just keep that in mind. The traffic in urban centers obviously is going to be higher, but it can be quite important in the rural centers as well, but usually it's going to be a little less busy. The level of involvement in the ER from the ER physicians tend to be a little higher, in my opinion, in rural areas, since in urban centers, consultants tend to be involved more quickly during the process. So sometimes they will be the ones making the decision about admitting a patient or what treatment to start, as rural ER going to make those calls. So you have to bring the patient a little further in the path to their definite care. Acuity is probably going to be higher in most urban centers, but you can still have some pretty high acuity in rural centers. So we see acute cases and unstable patients every day here, at least in our hospital. The variety is probably going to be a little higher in rural areas. It depends if you work in a specialized hospital. For example, if you work in a hospital that's specialized in pediatrics, you're probably going to see a lot of children. If you work at a trauma hospital, a lot of trauma, maybe less peds. It depends, but you still have to be ready to see every patient who comes through the doors. Sorry. About uncertainty management, you do have more resources in urban centers. So access to imaging, advanced imaging, and consultants, as I discussed. Whereas in more remote centers, you might only have, as I said, some labs, basic labs, and an X-ray. So you might have to transfer patients for a lot of things. So that makes things a little more complicated sometimes. You have to think about that. If is it really necessary to transfer a patient for an exam? Does the patient really need it? So that adds a layer of complexity sometimes. Teaching is going to be something that you're going to find everywhere in teaching hospitals, obviously, in urban centers, a lot of residents and medical students everywhere. whereas in rural centers, you can have some residents and medical students as well. We do have some here at least, but if you're very remote, you might not get students that often. So if you like teaching, you might have to consider that. And the resources are more abundant in urban centers, obviously. So it comes down to the uncertainty management point that I just discussed. Just a quick case to illustrate what it's like to work in rural environments. So this case was, this patient was seen by one of my colleagues who worked in the north of Quebec before she did her EM year. So she was working in Pure-Nituc. She saw this 30-something-year-old male who came in with suspected methanol intoxication, and the usual treatments would be fomepizole or IV ethanol, plus or minus dialysis, but they didn't have any of that, any of those. So they had to make the patient drunk, obviously, with some. They did give him some vodka to bypass the metabolism of the methanol, so it wouldn't be transformed to the its toxic metabolite. And the patient was transferred. Obviously, it wasn't kept there for all that treatment, but it was an option that they did have to use. So it's quite a funny case, in my opinion. Another case, one of my attendings, older attendings, had that case. I think he was working in Sept-Îles, which is a northern city in Quebec. 20-something-year-old male who sustained a head trauma, had a epidural hematoma. Glasgow 3, blown pupil, had to be intubated, but there was no time for transfer. So what they did is they did a referral to the patient in the ER with the coaching of the neurosurgeon over the phone. So not something that you see every day, but it's definitely not something that you will see in bigger cities, that's for sure. I think it was in the 90s, early 90s or maybe 80s. So I don't know if that would still be done today, but maybe, who knows. So now let's talk a little bit about the required qualities and skills that are, in my opinion, necessary to be a good ER doc. The first one is pretty obvious, would be stress management. So you have to be able to remain calm and focused when you have unstable patients who come through the doors. If you can't do that, obviously things are probably not going to go well. So definitely an important quality. A second one would be ability to adapt. So sometimes in the ER, you don't have all the information you need before you need to make a decision, and the best option might not be feasible in some instances. So you have to be able to sometimes choose another plan B or plan C, even sometimes with the resources you have or the information you have at that moment. And sometimes it's hard to make those decisions in those circumstances, but sometimes it's more important to make a decision than to make the best decision because you don't always have the time or the information you need when the patient is in an unstable situation or a critical state. Decision-making capabilities, that comes back to what I just said. So sometimes you have to think fast and you can't wait before you have all the info before you make a decision, because the patient can suffer from that if you wait for too long. Multitasking, fun fact, the ER docs are interrupted on average once every 5 minutes. So you have to be able to multitask. Sometimes you're going to be called to see a patient when you're in the middle of something else, and you have to come back again a little later to what you were doing. So it's sometimes it can be hard. If you're kind of person that has to finish one thing before he or she starts another, it might be a little hard to work in that kind of environment, but it's definitely something that is needed to work in the ER. And teamwork abilities. I think this one is pretty obvious. For some minor cases, not many people might be involved, but for acute critical patients, it's really a team effort. Not much can be done only by one person. So you have to be able to communicate well and build good relationships with your teammates. And finally, resilience and humility, I think, are good qualities to have because as ER physicians, we have to know a little bit of everything pretty much. So you can build a little bit of expertise in a niche that you like, but it's hard to be an expert in a specific field. So you have to be able to accept that you can't know everything and go get some help when you need it. And resilience because obviously not everyone can be saved. So you have to be able to forgive yourself and just accept that that's the way it is. And not everyone can be saved, unfortunately. So, questions to ask yourselves before choosing EM. I think we already covered a little bit that topic with the last slides, but some other questions that you might have ask yourself is if you like very short interactions with patients or long-term care. Long-term care. Are you someone who likes to know everything about the life of their patients? If you're that kind of person, ER it might not be the best fit, but it is possible to do, as I said, some other activities like longitudinal care in the office or hospitalizations that, for example, that gives you some more opportunity to get to know your patients a little better and still do work in the ER. So you can do both. Do you like routine or unpredictability? That's definitely something you have to think about. Do you prefer working in a calm and orderly setting environment, or do you thrive in a fast-paced and even sometimes chaotic environment? Are you comfortable making quick decisions in a certain uncertainty? Would you rather be an expert in a very narrow field or good but not necessarily exceptional at everything? And as I said earlier, you can develop some expertise in a niche like resuscitation or ultrasound, for example, but you can't know everything about everything. It's not like you're going to be a ophthalmologist who's specialized in the retina of the left eye. I'm exaggerating a little bit, but you get the point. And lastly, are you okay working evenings, nights, and weekends? Quite a significant proportion of the time, even if it means you can avoid being on call. As I said, one of the perks of working shifts is that you don't have to take calls when your shift is done, but it does involve being working a lot of evenings, nights, and weekends. So definitely something you have to think about. So now let's move on to what we could call the elephant in the room, which is the current state of emergency medicine in Canada. So it's not a secret that ERs are struggling right now. They have been for a number of years, and it's not expecting to get a lot better in the near future. And there are a lot of reasons for that. First of all, people are getting older and older. That creates more need for emergency physicians and a lot more people who comes through the ER doors. Patients have increasingly complex problems. Sometimes in some regions, a lot of regions are a lack of timely access to primary care. Some people don't have access at all, but also to specialists and some more advanced imaging. The hospitals are pretty much always full with no beds available on inpatients units and staff shortages. And all that creates overcrowding in the ERs. So people get stuck in the ER. Ambulances are put on awful delays. People have to wait in ambulances for a long time before they can get in the ER. And this creates a reduced ability to provide the actual emergency care that patients needs. In some instances, not always, but it's not as easy as it used to be. Some people end up getting the wrong care in the wrong place by the wrong provider at the wrong time. So some people get their primary care in the ER because they don't have access anywhere else. The quality of care could end up getting lower in some cases, and it creates a more difficult work environment, higher burnout rates, and among the emergency providers, doctors, nurses, and everyone. So this could sound a little depressing, I know, but this is the current state of things. But it doesn't mean that you should be afraid to go into EM. It is still a very rewarding and stimulating practice. And in the end of the day, we do our job and treat people who need to be treated. And it's very rewarding, as I just said. And there seems to be more and more um, energy and awareness about that problem. And we're starting to see some efforts to try to solve those problems. It's not going to happen overnight, but hopefully we're going to see the sun coming back from behind the clouds in the near future. So fingers crossed about that. But as I said, even though it's not always easy nowadays, it's still a very stimulating and rewarding practice. So, okay, 6:30. I was a little faster than I expected. That's good. Let's finish with a few cases, and then I think it's going to be the question period. First one. This one of my colleagues, when he was, I think, a medical student or maybe a resident, I'm not too sure, that had that case. He was doing a EM rotation in some more rural area, and he had this man who shut his truck door on his finger. So his fingertip was basically almost amputated, but the bone wasn't involved. It wasn't fractured. So no plastic surgeon or hand surgeon or orthopedic surgeon there, obviously, and they ended up just sewing that up, and the result was pretty nice. So good work for my friend. Case number two. This is a case that I had here in Edmundston maybe 4 or 5 years ago. This 67-year-old gentleman came in the ER. He had a severe intellectual disability and was nonverbal. So we basically didn't have any history with him. He was sent by his nursing home because he looked like he didn't feel well and vomited. This is the only info we had. He was hypertensive, 92/60, and heart rate was 80, O2 sats 97, and temperature 37. So what does an emergency physician do when he has to examine a patient? He takes out his ultrasound machine, obviously, and ended up performing the rush protocol for hypertensive patients. And when I got to the aorta, I got that. And now that's a video. I'm not sure I can start it though. Maybe someone could tell me if it's possible to start the video. If not, that's okay. Just want to check.
I'll
Okay,
throw that at Alyssa or Natalie. Any ideas?
Um, I'm not sure about the doing a video in PowerPoint. Alyssa, do you know?
It might work. I'm not sure. What we can do is we can always post the video separately as well, and insert it into our recording of the lecture afterward too, if that's an option.
okay, that's fine. That's perfectly fine. I'll just describe it. So basically, it's not a very clear image, but this is an ultrasound of the abdominal aorta. I was looking for AAA that might have ruptured and explain the hypertension. But what I did find instead was this. So this is the vertebra here, vertebral spine, and the aorta is here. This is the outer layer of the aorta, and we can see something here that if the video worked, you could see that this is moving, actually rhythmically, so like pulsating basically, and that was a flap. And we ended up doing a CAT scan, which confirmed what I thought, which was that this patient had a aortic dissection that type A that came from the ascending aorta. Here we can see the flap, the mural thrombus, and says the lumen of the aorta. You can see the flap here again. Here on the sagittal view, you can see the ascending aorta aneurysm and the dissection that starts from here and goes. It went down to the iliac arteries, I think. So if it wasn't for the ultrasound machine, I don't think I would have found that because he didn't have any pain, didn't seem to be in pain. Maybe we would have found it at some point, but the only reason I went with the angio CT scan was because we saw that on the ultrasound. So very interesting case. Not something we see every day, obviously, but it's just one of the many examples of um, the advantages and utility of the ultrasound machine in the ER. So next case, another case that I had not too long after that, maybe 4 years ago, we had that 58-year-old female who was known for chronic kidney disease and was on dialysis. She was known for CAD and type 2 diabetes. She was actually sent from dialysis clinic in the middle of the afternoon because she was persistently hypertensive. And she just didn't seem well. People get hypertensive during dialysis all the time, but this was pretty unusual. Her BP was really low, about 60/40 at that point. Heart rate about 60. O2 sats a little low, 88%. Temperature was normal. And she was like grayish looking, didn't look good at all, and was kind of restless. And she didn't have any complaints except that she felt weak. And we can understand why. So this is her EKG. And it was supposed to be an animation, but you got the punch now. We can see ST elevation in AVR and a little bit in V1 here maybe, but not as obvious in these as in AVR, and some ST depression pretty much everywhere else. And usually when you see that, it's not a common pattern, but it's either left main occlusion, acute occlusion, or a proximal LAD occlusion, and that isn't good. Those patients usually get into cardiogenic shock, and that is what was happening with this lady. I do have another ultrasound image. It was also a video. Unfortunately, we can't play it. And it was with our older machine. I didn't have the phase array probes or the cardiac probe. It was a curved array probe. So not a very good image, but we can still see here that the left ventricle, that big black balloon, was severely dilated. And if we could play the video, we would see that she had anterolateral hypokinesis that was pretty obvious, and very severely reduced ejection fraction. Sorry. And so at that point, we knew that we had to start pressors, and this patient had to be transferred emergently for a cath lab, which she did have. And she did have a proximal LAD occlusion during the coronary angiogram. So diagnosis was confirmed. And unfortunately, this patient ended up passing away a few days later, I think. But yeah, interesting case, but sad ending, unfortunately. And in conclusion, the emergency medicine is a pretty varied and stimulating practice. You can get many different practice profiles and training paths. I think it's good to know yourself before making a decision on which way you want to go. Either if you want to practice emergency medicine, of course, but also, or do you think you'd be a good fit for the family medicine route, or a family medicine +1, or the specialty program? These are all things that have to be considered, and I think the best thing to do is to talk to some of your mentors and attendings who do have that background, and trying to see if you have the same motivations as them, same reasons, and make a decision about that towards the training paths you want to go through. And there will not be a shortage of work for ER docs. I think we covered that pretty. That's pretty obvious. If you want to work in an ER, you're going to have work pretty much anywhere. It might be a little hard to get a position in some academic centers sometimes because more people want to work there, but you can still have a very interesting practice in some semi-urban or even rural ERs. So definitely something to consider. And as we discussed, many challenges face the emergency departments right now, but we're working on that. Everybody wants things to get better, and even though it's not always easy, it's not always rainbows. It can still be a very rewarding and stimulating career. So I don't think it should be something that you worry about too much when you're making your career choice. So that ends the presentation. Here are my references for people who might be interested, and I'm ready for some questions.
Well, first of all, thank you very much for a great lecture. Thanks for coming and delivering it. Before I pass it on to Alyssa, I'd like to thank Natalie for putting it on. And a couple questions I'll just leave you with, because one I thought the students would like is that at what point in your career, what point in medical school, do you think, aha, I want to do this? This is the one that got me. And the other question I had for you before I leave you is, how close is your portable ultrasound in replacing your stethoscope as you walk to see a patient every day? So listen, thank you very much. I'll leave you with those two. And Alyssa, you're in charge.
Thank you, Dr. Simon.
Bye-bye now.
Yeah, so for the first question, which is a very good question, actually, it's kind of interesting because when I went to med school, I never would have thought that I would go into EM. I thought I would do some longitudinal care. I saw myself doing that, and for some reason, I didn't really click when I did it as a medical student. So not that it's a bad thing to do, but I just didn't feel like it was the right fit for me. And I was always excited to go to my ER shifts, and I had very motivated attendings who it really seemed like they liked their job, they loved their job. So it's nice to see that, and I fell in love with it mostly because of the variety that comes with it. And as I said, the fact that you can do a big difference very quickly and see the results of your action very quickly on shift. And as I said earlier, a lot of intellectual work, but also a lot of technical work, which is very nice to do. So I think it was during one of my rotations in the ER as a medical student during my clerkship that I decided to go into emergency medicine. It wasn't an easy choice, to be honest, but I'm glad I did it. And if you recognize yourself in what I just said, it might be a good fit for you too. And for the second question, the ultrasound machine is not very far. It's always close by. I still use my stethoscope on pretty much every patient. I have not replaced the stethoscope with the ultrasound machine. Sometimes you can have the same answer with the ultrasound machine, but it might be a little longer just to set it up and everything. So just we have to be conscious about the time management in the ER. So sometimes when it won't bring a lot of value, I won't take it out. But if I think that using the ultrasound machine is gonna bring me information that I wouldn't have otherwise, or that would have been longer to get, I won't hesitate. And as I said, most of my fellow EM doctor friends and colleagues would probably agree with me. We use that every shift, and it's a great tool. I like it a lot. So it might not be interesting for everyone, but I do like it. And that's a picture of myself, by the way. I don't know why he was doing that gesture, but I thought it was funny and was a bit for the question period. So.
Oh, it's wonderful. No, and thank you so much for addressing those two questions. I've got a few of my own, and before I start, I want to let any students or any attendees know, drop your questions in the chat box if you have them. We'll make sure that they're looked at and asked as well. My question for you, Dr. Moreau, is if a student is really intrigued, if they think, okay, emergency medicine is definitely a possibility, I want to think about this and pursue it possibly. Is there anything they can or should be doing outside of the required kind of academic time in the ER that can help them either gain exposure, if they're volunteering, things like that, to give them a better chance of moving into that field successfully?
Yeah, it's a great question. So I think obviously choosing your optional rotations in emergency medicine or critical care or anything that's related to acute critical care in general is a good start. Getting involved in some other things might be good too. You can get involved in some research project, for example. You could organize organize an EKG course when I was a resident, and an ultrasound course as well. So if you want to take that initiative and bring some of those people to your faculty, that could be a good idea. If you want to work, for example, as a volunteer, as a medic for some marathon, for example, or some sporting events, anything like that, I think that's a good thing too. Gain some exposure with paramedics, always good experience. I know that a lot of paramedics, a lot of ER doctors used to be paramedics before they went to med school, so that's interesting. And maybe just shadowing and trying to connect and network with ER doctors that you get along with, and go to conferences and talk to people and get as much information as you can. Try to know as many people as you can. It's always good. But basically, it comes down to the interest that you're going to show when you apply for in the EM program. And I think all those things could help a lot.
That's wonderful advice. I think what we'll do is we'll actually summarize some of those points and send that out specifically as, for our students who are interested in emergency medicine, because I know there are many. My next question is, we talked about, the progress with ultrasound and how through the cases you mentioned, that was life-saving, a huge intervention that was made possible through technology. Are there ways you see the emergency medicine profession evolving with new technologies, with innovation that we hear about, whether it's AI or whether it's EMR or different things that could save time and make things more efficient, but also, help make life-changing decisions?
Yeah. It's very interesting topic because AI is obviously pretty popular subject at the moment. At the moment, some doctors are even afraid that they're going to be replaced and be out of a job because of AI. I don't think we're going to see that at any time. Actually, not in emergency medicine. I couldn't see how a machine would use AI to intubate a patient. That doesn't make any sense. I think it's going to be used, and it already has started in some hospitals, I think, mostly with information recording and charting. So I know there are some places in bigger cities, bigger ERs that use softwares that listen to the conversation between you and a patient and just writes a note, and you don't have to do it. So it saves a lot of time. We're probably going to see some more of that towards helping us with differential diagnosis and choice treatments as well. I think radiology is a big one. Obviously, it's not our specialty, but we work with that every day. So I think we're going to use that more and more as a tool. I don't think it's going to be replacing us as doctors, and just the personal and the human connection that we have with our patient can't be replaced by a machine, obviously. And this is something that has to be considered in the equation. About EMRs, I couldn't talk too much about that because here we don't have EMRs at this moment. I know this is coming in maybe a few years. I think that it's going to help standardize a little bit more the work, but as I said, I haven't experienced it too much. So, and even not as a resident 7-8 years ago. So I'm not too sure how to answer that question, unfortunately, but yeah, I guess it's probably going to be coming in most ERs in the next 5 to 10 years, I assume.
Okay, well that's fascinating, and I completely agree with you. I can't imagine a world where AI takes the place of a physician. I just don't think that's in our reality. I certainly hope not, as a prospective patient. But we do have a question from an attendee, from Madeline Power, who says, "Hi, Dr. Moreau. Thank you so much for such an interesting presentation. I was wondering if there is any difference from a hiring perspective between the FMEM and the FRCPC, aside from wanting to work in an academic center with FRCPC. A preceptor mentioned to me once that some hospitals may have only a certain amount of spots available for FRCPC trained physicians."
Yep, that's true. I know that mostly in teaching hospitals, there are going to be some positions that are open for FRCPC trained physicians and some other positions for CCFP EM physicians. So if you really want to work in a specific city, you might have to consider that and maybe try to get that information beforehand, but it might be hard to predict because the specialty program is 5 years, so it's sometimes can be hard to predict what the needs are going to be in 5 to 6 years. But it's something that, yes, has to be considered. As I said, it's probably easier to get a job at some place you like with the FMEM route. Because if you decide to work in a semi-rural region, there might not be FRCPC positions. I don't think that would be an obstacle to getting hired, but I assume that people who go through the 5-year specialty program probably want to work in a bigger ER with more teaching and academia in general. So if your main interest is, I would say, clinical emergency medicine, and you'd like to have some freedom to maybe do something else and have the freedom to work pretty much anywhere you'd like, the FMEM route is probably a better choice. If you're very interested in research and academia, teaching, and know you want to work in a teaching hospital, maybe with more acuity and a lot of busier ERs, then the FRCPC might be a better choice for you. But as I said, I think it comes down to talking to people, get to know your attendings, see what kind of training they did, and talk to as many people as you can to see what is the best fit for you.
Thank you very much, Dr. Moreau. Because I'm cognizant of time, and I know we want to end at or before 7. And Madeline just says makes sense. Thank you. So thanks, Madeline, for the question. My final question then, it's going to be a 2-parter. First of all, over your career, has there been either anything that has really surprised you about either the function of emergency medicine or working at the hospital, or a case that you're really, really proud of? And my second question is, how do you see your career evolving, knowing that there are these other options and this flexibility available to you?
Okay, well, you really do have good questions. So the first one was, is there something that surprised me, you said, by working in the ER that I didn't expect? Was that the first question?
Yes, that's right.
Okay. I don't really have a quick answer to that. Let's say maybe and that's why I wanted to touch base on the crisis we discussed earlier. I didn't expect emergency medicine to change as much as it did because of other problems that are not really related to emergency medicine. So this was a little bit of a surprise for me when I was a medical student. At least where I did my residency, most people had a family doctor at that time, which is not the case anymore. So I think emergency physicians, either if they choose to go through the specialty route or the family medicine route, have to be able to do something more than just acute care and be ready to do some care that are not urgent, but be even more versatile than they were before. So that might be something that not surprised me, but I didn't necessarily expect, and that's not a bad thing. I mean, yes, it's cool and stimulating and exciting to have an acute case that you can solve and everything, but sometimes having more low acuity case are nice too. So it's good to have a broad knowledge base. And the second question, I think, was if I had a case that was very proud of? Was that the question?
Yes.
Okay. Again, I don't have a specific case in mind. I think that probably everyone will agree with me that we decided to go into medicine to help people. And when someone comes to you and genuinely thanks you for the care you provided, that's always what keeps you moving and wants you to come back to your shift the next day. So just in general, having those patients who come and show that kind of gratitude. And sorry about the bell. And a specific case that I was very proud of, I'd say that the case I presented with the aortic dissection was one of those. Probably those cases would probably be related to the use of ultrasound machines because I just like those very much. We also had a few patients who came in with massive pulmonary embolism that we could diagnose more quickly because we had the ultrasound. So it's nice to have this skill that gives you the opportunity to find a problem quicker, and sometimes that can mean that you get the treatment sooner and potentially save the patient's life. So I think that would probably be one of those. I think about some trauma cases too that were pretty critical and ended up being patient's life ended up being saved. So that's always very gratifying. So yeah, I think that would be my answer.
That's incredible, and I do have to thank you as a layperson for the work that you do to save lives. It's really a pleasure to work with so many physicians, knowing that they give so much time, effort, etc., to others, and that's a wonderful, wonderful attribute. So my final question was, where do you see your career evolving?
Yeah. Sorry about that. My brain is kind of working on low battery right now. So as I was saying a little earlier, it's not necessarily a downside, but you have to be cognizant of the fact that you're going to work evenings, nights, and weekends. And I realize I'm 7 years now into my career. So I've realized by having a son, having a family, that it can get a little trickier to go navigate through this kind of schedule when you have a family. So I'm definitely thinking about that. I'm not thinking about leaving emergency medicine because this is what I like to do the most. As I was saying, I'm happy to have done the family medicine residency before EM because I have the freedom to change my practice. So at some point, I might end up doing a little bit less of emergency medicine and do something else. I don't know what it's going to be. I'm not planning anything specific at the moment, but it's definitely something that I think people have to consider. Even though you're not working clinical EM anymore, at some point during your career, you can still get involved as for example, a medical director, administration, in teaching for teaching programs with students. So there's always a way to keep your foot in the field and changing your activities at the same time. So that's maybe what I'm going to do. We'll see. But for now, I'm not ready to step back from the ER. But as I said, it's nice to have the freedom to do so if you decide to do something else as you get a little older and tired.
And that makes total sense to me. So thank you so much. With that, I think we will close the webinar. But just for everyone's information, this has been recorded. So the recording of this information session will be shared to our website, to our YouTube page. So you can certainly watch it in full again if you want to circle back. We'll be sending some notes as a summary as well, just some key takeaways, contact information. Reach out to us if you have any further questions for Dr. Moreau. We're happy to pass them along. And I know sessions like this don't come together miraculously. I know, Dr. Moreau, you spent a lot of time pulling all of this information together, as well as delivering it in such a wonderful, comprehensive way in a short time frame. And Natalie, I know you pulled all this together. So thank you both so much for taking the time to do this. at the New Brunswick Medical Education Foundation, we really do want to continue offering these information sessions. So finding, the experts, ensuring that we can connect them with our students is such a wonderful thing that we're able to do. And to the students who are on this call or who are watching the recording, I'll just remind you that applications for scholarships open in March. So just expect lots of communications around that time, and we hope to hear from you all then. So thank you so much, Dr. Moreau. Are there any closing remarks on your end?
No, I just want to thank you guys again for the opportunity and the great work you're doing, and thanks to everyone for coming. I was very happy to be here tonight, and as Allison said, you can send me questions anytime by email. I'll be happy to answer those. So just no, sorry, I said Allison, but it's Alyssa. I apologize.
Not a problem.
Send me an email. I'll be happy to answer your questions if you have any.
Wonderful. Thank you so much, everyone. Have a lovely evening, and we'll be in touch soon. Thank you.
Thank you so much. Have a great night.